welcome to you. This is Platform. I'm Ruth Aguela. Effective health insurance services to citizens is a fundamental human right. And to achieve that efficiently, there must be an expansion in health insurance coverage by strengthening primary health care and ensuring financial protection against healthcare costs. A report by the National Health Insurance Authority reveals that about 20 million Nigerians have been enrolled in the National Health Insurance Scheme. Now, as part of its mandate towards ensuring universal health coverage and improving quality service to enrolled patients, recently the National Health Insurance Authority sanctioned 49 erring healthcare facilities and 47 health maintenance organizations under the 2024 Annual Complaints Report in accordance with its operational guidelines. Now, the action followed investigations into complaints received from patients enrolled into the state and national health insurance schemes. Some of the key issues recorded in the complaints include unavailability of medicines, denial of services, out-of-pocket payment for covered services, and non-provision of payment narrations. Now, for the HMOs, that's the health maintenance organizations, the issues related to delays or denials of referrals authorization codes, delays in settlement of agreed reconciled payments, refusal to monitor quality assurance in facilities, among other related issues. The authority says this is part of its commitment in promoting transparency, accountability, and continuous improvement in the provision of healthcare services to beneficiaries, and a furtherance of President Bola Tinubu's vision to make universal health coverage a reality for all Nigerians. Well, you say so far looking good, but what are the mechanisms in place to sustain strides recorded in resolving complaints from enrollees? On Platform, we explore ways of improving quality services through universal health coverage in Nigeria. And our guest is Dr. Habib Abdullahi Abdulhamid. He's the Acting Director, Enforcement for the National Health Insurance Authority. Thank you very much for joining us, Dr. Abdulhamid.
Thank you for having me.
We're pleased to have you here. And of course, you know, as part of our tradition here, we'll let you in on who our guest is more appropriately by, reading out their profile. Dr. Habib Abdullahi Abdulhamid holds a Bachelor of Medicine and Bachelor of Surgery degrees with postgraduate degrees in public health, as well as health planning and management from the University of Ilorin. Dr. Abdulhamid is a health systems strengthening enthusiast with special interest in healthcare financing, an alumnus of the World Bank Institute flagship course on health sector reform and sustainable financing. He also obtained a certificate from the University of Washington, Seattle, USA on project management in global health. He has worked with the NHIA North Central Zone Office in Kwara State. He has served as Standards and Quality Assurance Department. That's at the head office. And now I told you earlier, he's the Acting Director Enforcement. So he will be telling us a lot on how this enforcement is coming along. Thank you once again.
Thank you for having me once again.
All right. And our panelist is one of our health correspondents here in the NTA, Uche Ugochukwu. Uche, thank you so much for joining us on Platform.
It's my pleasure.
All right, so Dr. Abdulhamid, going by the recent report, the authority reeled out in the sanctioning of HMOs and HCOs, it says a lot that, okay, there's a wake-up call. That actually was a 2024 report, so to say, and we're in 2025. And I'm sure you want to keep the momentum going, right? So tell us what, prompted all of that.
Okay. Actually, the enforcement function in the NHIE has always been there. It's a department. Now it became a department in 2016.
Okay.
Before then, it was a division in the Standards and Quality Assurance Department. And so that function has always been there. This report isn't the first. Okay. Probably this has got more media coverage.
Yes.
I think by 2021, we started annual reports. But the Act of 2022 actually specifies that a mechanism be set up by the authority that enrollees or stakeholders generally, because these complaints are not only from enrollees
Yes.
against HCFs, that's the providers, hospitals, if you like, or the HMOs, but even HMOs can complain against enrollees or against hospitals, or hospitals can complain against enrollees or against the HMOs.
So it's a two-way thing?
Yeah, I mean,
Okay.
in the course of interaction in any ecosystem, stakeholders would have some dissatisfaction with one another in probably some actions that were taken or decisions that were made. So for us in the NHIA, as far back as even before the Act, we had started what we call the Complaint and Grievance Management Protocol. So we began to develop that because we saw that there was need to have that interface through which any of these stakeholders can complain against the other. So we're done with that, I think, by early 2023, when the present DG came, and it's in form of a document. And I think we also have it on the website. And it spells out the procedures, so anybody can complain against the other. And what the authority has even gone further to do is that in the line of decentralizing our function, I mean, here in Abuja, we have the head office. But in every state across the federation, we also have an NHIA office. We have an enforcement officer or a complaint officer in all of these states. So anybody who is aggrieved with the other can either walk in or can make a phone call or can send through the email. And sometimes we even pick from news like this, from media, social media, at workshops or meetings, people could come up to say, oh, I have this complaint against the other. So we have that business process that spells out when you receive the complaint, what you do with it, at what stage it moves on to the investigation officer. And beyond that, we even categorized these complaints: top, medium, high priority, the timing within which investigation will commence on them, and even the resolution timeline. So all of those we put in place, and then we went ahead to develop that system of collating these complaints, analyzing them, and bringing it out in a report, just like we did.
Okay. I'm sure we'll break down some of those complaints because these are daily issues we keep seeing. Yes. Uche, I'm sure you want to come in.
Yeah, sure. First of all, you talked about the complaint system, having been in place even before the 2024 report. So, but my issue is, how many of these enrollees are aware that they can actually report HMOs or health facilities? What are you really doing to ensure that, of course, when you prepare something for someone and the person is not aware, it's there for him to eat, it's as good as your efforts are wasted. So what are you doing to ensure that these enrollees, whom this complaint mechanism is meant for, actually make use of it? Okay,
thank you for that question. And I think it's, a lot of the times I tell people that we're talking about 3,000 plus in this 2004 report, but I'm sure there are even more complaints than that didn't come in.
Yeah.
And that's because some people do not know. So bringing out this kind of report like we did is just to let people know. I was telling my staff maybe a couple of days, I said, with this report now in the media, the momentum is high and we'll even be getting more of the report. But what we have done, for example, in the past is during sensitization and awareness, a lot of citizen engagement has gone on to MDAs, to let them know that, look, you could report. I think on the average, if you walk into any healthcare facility now across the country, you will see that post at service points that will say, if you have any complaints or any dissatisfaction with service provided at the facility, get in touch with this number or send your complaints to this email address. So on the average, I'm sure if you walk into any facility, you will see that, because that is what we have advocated as part of our enforcement quick win measures.
So when you say when an enrollee walks into a health facility that has the coverage, is there like a signpost or a hotline or something? How do I know where to go to? I think that's the question she's
So
asking.
no, but that's the response I give, that if you walk into facilities
And
now,
that's what I'm asking. Are there
to
signposts?
identify the
Yes.
facility itself
Yes.
as yes.
Okay.
In fact, upon accreditation, you get a sticker that says NHI accredited facility.
Okay.
So that is one. Then what we say now is even in the facility, within the facility, at service points, probably consulting area, the pharmacy, the laboratory, there are also posts. Now this is posted, I mean, we actually directed state offices to do that. Because like I told you, the complaint process itself starts even from the state level. So in every state, in all of the facilities you go to, at service points within the accredited facility, you see this post that says, if you have a complaint, get in touch with this phone number or this email address.
So is it just documentation we're saying? What were the penalties for this airing HMOs and all of that?
So probably
and also,
now
what's the
coming
benefit for the enrollee? What did they get in return for laying that complaint?
Okay, so probably just breaking down the whole complaint handling process. So like I said, complaints are received at the state level, you know, either by the enrollee walking in or sending through the email or through the phone. And then the first step is even documenting that complaint appropriately in what we call the request for intervention form. So details about the complainant, details about the complainee, that's the respondent, who they are complaining about, when it happened, at what time it happened, if it was the first time. So all of those are done even at the initial level. And then when you have confirmed that, yes, truly this requires investigation, then it goes to an investigation officer who does that investigating. And investigating could take any form. It could be on-site visit to the facility. For example, if you complain about poor service in a facility, we may want to even see the records, the medical records, how you were treated. So we may visit the facility. Some of the time we write and request for them to respond. I mean, sometimes some cases could even be resolved on the phone. You understand? So we document all of that. And at the end of the day, if you are able to ascertain that indeed a breach has occurred, because in the operational guidelines of the NHI, we have what we call offenses, you know. So for every provision that is made in the guideline, anything done contrary is an offense, and it has an appropriate penalty. So the penalties is a regime. It could start, for example, if it's, let's say, a medium priority complaint, or it's a first-time complaint, probably you get a warning. You know, sometimes it could be a warning plus some other things, monetary penalty. It could be a suspension or a delisting, or you ask someone to refund. Sometimes it could be institute a corrective action, or we've observed something because an enrollee complained. We warn you, and then we tell you correct this thing, and then somebody will come later on to check. So apart from even the fact that people could come to complain, now we even do mystery shopping. You know, so unannounced, people walk into the facilities, the hospitals, and pretend as if they are enrollees, you know, and just see what is happening. And at the end of the day, they now seek to have audience with the management that we've been around for so time. And these are the things we've observed. Even at that point, not only that we receive a complaint, the facility could still be sanctioned. You know, you are warned, or you need to pay this penalty. So that has happened over time, and that's what we reported in this 2024 report.
Okay, now I'm talking about the complaints. Yes. Fine, yes. When I walk in, I see the signposts for those that can read, of course. Many people cannot read. So, and I make complaint. Of course, going to the hospital, I have some ailments that took me there. The duration, according to your report, is not more than 1 hour. Fine. Okay. So what happens after the complaint? You know, it's been made. Sometimes when you call the numbers there, I know there are numbers. If you don't get to receive answers immediately, what happens? Because someone who is ill already is waiting for a response to be attended to. And of course, you know, without the authentication, you will not be attended to.
Yeah.
Okay.
So what do you do to ensure that even when the complaint, you're processing the complaint, that whoever, the patient or the enrollee, will be able to access at that time?
Okay, so I think your question actually bundled a lot of parts. Yes. So what you're talking about, the 1 hour, refers to the authorization
Code,
for
yeah, the
referral.
code, yeah, referral.
So that one is talking about when you've gone to your primary facility, the facility you chose. Usually the facility you chose are supposed to provide primary care for you. But you may now need to access secondary services. And so that facility will call your HMO and request for authorization to refer you. Now, they may refer you to an external secondary, or if they have the facility within, they will refer you to themselves. So that is now what we were talking about. So I think earlier this year we observed from even previous complaint reports that there has been delays, in getting this code. So that policy came in that it shouldn't exceed an hour. And then we brought out directives on how that can be implemented. So what it's saying is, at the point that the primary facility has requested for authorization, count 1 hour. Once it is 1 hour, the facility should go ahead to provide the care to you. At that point, they communicate with NHI through call center at nhi.gov.ng. Enrollee has been here for 1 hour. This is evidence that we've requested for code. We are going ahead to provide service. So at that point, it is now on, the burden is now on the facility. It's no more, HMO did not provide code. It's you, facility, now, after 1 hour, provide the service. If you don't, you have also committed a breach. So, but some of the facilities, but will we get paid? That's why we say send that email. We are documenting it in the enforcement department. And after 30 days, when you provide your claim to the HMO, they have to pay you, because we will make sure they pay you. So that is concerning authorization. The other thing is about people going and then seeing a number and calling. I want to say the response time to complaints, even in the NHI, is, very impressive. If you compare it, and we've had experiences with other, even regulatory sectors about timing. So, like I said, the states have all of these telephone numbers, and immediately you get across to them. There are complaints that are settled immediately. We call them rapid response. So immediately you get some sort of complaints like, I'm in the facility and I cannot access care because they say my name is not in the register. The person you're speaking to only needs to confirm that your name is in the register from his end. And once it's there, he gets across to the facility to say, no, go ahead and provide service. There are some other ones that will require investigation. I know investigation sometimes a week, some days, but at the end of the day, we have been able to at least achieve an average of even 15 days for those ones that we investigate. But like I said, a lot of them are rapid response. Immediately, you call the HMO or you call the facility and you are able to resolve it. But all in all, 20 days is the exceeded timeline for even the top priority complaints.
I'm just concerned about those in the rural areas because this coverage is supposed to be for everyone. Yes. And the way you're saying it will take a lot of innovation, technology to make it seamless, talking about the process. You talked about your awareness campaign you take once in a while, but are you taking it to the grassroots? Because if you have the state offices across the country, we have local governments of about 20 or 30 in some states. So how do you expand or decentralize even at a state level to ensure that everyone is aware and have access to this coverage?
So, well, in terms of access to coverage, I think it's apt to say here that coverage does not mean only NHI schemes. We're doing this thing together with the state health insurance agencies and even the HMOs who have private health plans and so on and so forth.
But you're working in synergy.
So we all work together. I mean, we regulate them
Okay.
as the regulatory body, promote and also integrate all of these schemes. So the NHIA manages or implements the formal sector program, as well as other programs that we've developed, like the giftship, the group, individual, family program. That's for the OPS. The HMOs have their plans, and now virtually all of the states, I think all of the states in the Federation now have their own health insurance agencies, either health insurance agency or contributory health management, agencies and so on. And they develop programs as well, and for their formal sector, for their informal sector, and then there is the one we all do together through the Basic Healthcare Provision Fund, whereby the federal government provides the funds, the counterparts, and that's the one to provide for the indigent, which are the people you're talking about in those areas. So in a lot of ways, I am aware, even within this week, there are some programs going on for the BHCPF across the country. So we use all of those opportunities to sensitize them about these things. We know that technology may not really be found there, but honestly, we're doing a lot of things in terms of technology.
What about radio jingles, television?
We've had, I'm sure you've run all of that before for us. We've had programs we used to run weekly on NTA. I think they are reviving it now and even looking towards maybe a series of drama programs, that can just be televised to make people more aware that health insurance is the preferred mechanism to finance healthcare. So all of that is at the offing. Enrollment by self-service platforms, even the complaint itself, a complaint app that people can download.
Do you have the app?
From Google. In the
Like
matter of, we're working on it. In a matter of weeks, probably, that should be launched. People can sit in the comfort of their rooms and enroll, make complaints, change provider, or add additional dependents. The present DG, those are the kind of innovations that he has brought, and in a matter of little, maybe number of weeks, I think they should all be done with.
Okay. Uche.
Okay, no, I didn't want to cut him short when he was talking about the hospital, because I think after this sanction, some hospitals, or those that were sanctioned, of course, the enrollees were moved to different facilities. To believe so, but some of them, because about 2 weeks ago, I overheard an enrollee saying he went to his hospital, and the doctor told him, "You're no more in my hospital. You've been moved to a different facility, so I don't even know who your HMO is." Okay. So he was like asking, "How do I get to know? Because I need to get something from the HMO." Okay. So how do you, enlighten or make people aware of, especially HMOs? So, health facilities, yes, people know, as the intro said. The HMOs, lots of people are not even aware.
So I think basically, and I was mentioning that before the program with you, that is on us. I mean, the civil servants especially, because every MDE, ministry, department, and agency has an HMO, that is peculiar to it. I mean, they choose the HMO, and they choose them and change them even when they want to. It's their right to do all of that. But unlike what you see with all of us, I mean, everybody knows his pension fund administrator, for example.
Yes.
Because it has to do probably with money. But people...
Well, health is also wealth.
No, but people... So what I'm saying is the MDAs themselves chose these HMOs. And I am also aware that every MDA have a desk officer for NHIA. So like here, for example, I'm sure there is a personnel of the NTA who is in charge of, NHIA for the staff here. So these people are on WhatsApp platforms created by each state office. We made them do that. They have a platform where all the facilities in the state, all the representative of MDAs are there, and representative of HMOs so that they can also interface in case there are information to share or they have complaints and so on. So, and then it's also on the website. You have FDA and this is their HMO, you know. So I think it's on us to take interest in, you know, our health insurance. Okay, I'm going to be accessing health insurance. Before now, a lot of people probably do not access it, but I'm aware now there is great utilization because everybody now feels, no, I don't want to spend out of my pocket to access care. You know, so every MDA has an HMO assigned to it, and it's our responsibility to know which is our HMO. The addresses, the phone numbers, the MD, the email addresses of all of this is all on the website of the NHI. So probably civil servants should go beyond, you know, take it a step higher to find out about things that really concern
Okay,
us.
now how can we make it simple for a person like this, the scenario I explained?
So,
what should a person do?
So that person, for example, that went to the hospital and the hospital is saying your name is no longer with us.
They don't operate NHI anymore.
The facility does not operate
I think they're
anymore.
one of those.
So what we, from the enforcement department, because some of the time, I mean, maybe we even proposed or made that recommendation that that facility be delisted and, from the register. So what we usually tell the state offices to do is to communicate with the MDAs. You know, in the register, against everybody's name is even the code that will tell you, oh, this person works with this place. Yeah. So what we tell them to do is aggregate all of that, identify those MDAs, and then communicate with their desk officer that, okay, these people from your MDA who use this facility have been moved to this facility. Okay. So it's either there is, and I'm sure we've done that, but probably the MDA does not have maybe a platform for disseminating that information. But at the point where she found out that her name wasn't there, she could just get in touch with the NHI.
Okay. Dr. Abdulhamid, we'll pick up with the conversation. We have to take a break. We'll be back shortly. Stay tuned.
What are we doing as a nation to, first of all, settle our teeming populace, especially the
NTA's political package with a third eye on the nation's political scene? I am Fisa Ogunfuyi. Welcome.
You have to be very careful giving space to people who are obviously sponsored to further the agenda of some other groups.
There's a lot of questions. A lot of questions in a closed-door sessions. Some of these issues, some of the problems bedeviling their
In fact, between June 1st and July 17, 19-point-something billion has left the coffers of the NDDC.
I can say my constituency, they need everything because we don't have anything.
A method for digital literacy is a bot that you can use, you can interact to learn more about digital literacy.
Hello, it's our pleasure to have you join us on platform. I'm Ruth Aguwele.
What is the yardstick for measuring everybody's moral integrity? It's critical at this point in time.
How daunting has that been for the Institute in getting them abreast with all the legislative procedures?
The fact remains that one training workshop is not enough.
Thank you for staying tuned. The conversation is improving quality services through universal health coverage. Dr. Abdulhamid, something very important, if you say you have your offices situated across the states, 36 states and the FCT, how do you ensure monitoring? Does the authority has the capacity, the manpower, to evaluate all the reports together?
Okay. Yeah, thank you for that question. There's actually a robust monitoring system for monitoring the activities of both critical stakeholders, the healthcare facility, as well as the HMO. So we conduct quality assurance activities as well as compliance assessment exercises. We call it regulatory compliance assessment to evaluate the quality of service that are delivered by these stakeholders. And this takes place at the level of the states. So a quarterly thing in terms of the quality assurance, same thing with the regulatory compliance assessment, which seeks to evaluate the gap between what the facility is doing and what the operational guideline actually provides. So this takes place quarterly across all of the states and even zonal offices. So apart from the 36, in fact, we have 38 state offices because we have 2 in Lagos, Yaba and Ikeja office, and then about 9 zonal offices. So they do all of this in conjunction with the zonal offices at that level, and then the report comes to the head office for analysis, and even from that level of monitoring, they could also recommend sanctions. I mean, if they find out that any of these stakeholder has actually been breaching the guidelines.
I'm just curious, what is the authority contending with in the aspect of challenge? Because you make it look seamless, like all the processes just go seamlessly.
We have our challenges. I mean, challenges in terms, maybe you're now talking operational challenges. Of course, operational challenges will be there just like any other place. You know,
I'm talking about in compliance level with the HMOs. The HMOs. And, yes.
No. So but we find out when we do these activities. Yes, we find out people who are not doing the right thing. You know, and at
do
that
they
level,
fight back? Is what I'm asking.
No.
Do they resist the sanctions?
No, they do not. We're a regulatory body, and the Act has invested or empowered us to do all of those things. You know, so. I mean, if a facility hears, for example, that NHI is around, they will sit up. Or even HMO, you know, that the NHI is calling. And or we send a letter to you and we're telling you, respond within so time. They will do it because we are the regulators. And we have this weapon, these sanctions, which we can use against them. So, but you know, in every system, there will always be people who want to game the system. I mean, whatever you see happening in the system is not alien to us. It's happening even in the most advanced democracies. In the US and Europe, where insurance has been there for decades, you still find all of these things happening, even at a large, scale. So they don't push back. They don't. In fact, when you suspend, once the 6 months or 3 months is all, you see letters saying, please, we want to come back,
Okay, now I'm talking about monitoring now. And you just said, just as my colleague said, that it seems seamless. So what happens, like, personally, I had an encounter recently. In a health facility, it's like virtually all the medicines, the side we don't have supply, none is covered by NHI. Not that they are not available. Talking about out of stock. So virtually everything, even PCM, you have to buy. So what do you do to such facilities? And I asked why. I was told that we have not been supplied, that we've not gotten NHI supply for some time now. So what happens to such facilities? What do you do to them? And the patients, the enrollees themselves, what happens? Of course, they've been contributing. What happens?
Because that's where they bring out of pocket
exactly, and I come to that facility knowing that I'm going to pay maybe just 10%. And at the end of the day, I'm paying 100%. So what happens, especially where there is no supply entirely?
So I think it's a misnomer, a misrepresentation if they say the NHI has not supplied. Because the NHI does not supply them.
I was going to ask
you. It's like saying, of course, I know it was the meant HMOs, but of course, when they say NHI, that's the one everybody understands. So that's why they use the word NHI.
So either the NHI or the HMO is not responsible for the supply of medicines or consumables in the facility.
So what happens?
So
what's responsible
so
for that?
the facility may be up to some game. You understand? And it's an infraction if prescribed covered medications are not given to the enrollee. And at that point, the only thing the enrollee needs to do is just to notify the NHI. Even at that point, you notify the NHI that I am in my facility and I cannot access the prescribed medication. If NHI hears, we would want to know, are the medications covered? If they are covered, then you do not have any excuse not to provide the enrollee with it. Even in cases where they are not covered, we ask that please provide them with medications that are covered. Because for everyone that is not covered, a substitute, something in the similar that will do the same, work. I mean,
yeah, sure,
should be available.
But while this is going on, what should I, as a patient,
That's
do
what I'm saying.
at the time, because I need the drugs?
Get across to the NHIE, that is one, to say this is what is happening.
Okay.
Our rapid response team.
Would the patient be referred to another facility?
No, at that point where we get to hear that, oh, I'm here and I'm not getting my medication, the next thing is to get across to the facility. And why is that happening? Okay. At that same moment, just hold on and then get across to the facility and then resolve it around, if it's, I've run temporarily out of stock. There is even that provision in the guideline that says you could make arrangements elsewhere. And it's happening in some places. Oh, hold on, we've just run out of stock. We'll get it from the next place. If it's for probably conditions that are not acute, that is, it needs immediate care. Maybe somebody who is on some long-term medication, they even tell them, it happens, come back tomorrow morning. Or facilities make arrangements with some pharmacies and ask them to go. So these are all the things that happen in the system. Maybe it's not happening in your place, but even as it happened at that, get across to NHI resolves it immediately. Or you could go ahead if you have the money to pay. And then,
so why sign up under the coverage?
No. But that's what you did.
Yes, but which shouldn't be.
But what I'm saying is pay, and then we'll make that refund. So that's
okay. There will be a refund.
Yes,
that's the hope I want to hear.
That's what you see. The sanction report you read about 4 million going out from facilities to enrollees. They were made to refund.
Okay,
those
so
enrollees.
Now, very important, because you've mentioned the services or benefits covered. A lot of people are still not in the know of the kind of services that are covered. People still assume, I was just reading, doing some research on this, and I found that tuberculosis and even HIV has been included. There's some even fistula for women. Yeah. So why are people not still aware? Where is that? Why are we still having that gap? A lot of people still don't know.
So it's like what we mentioned while we were talking earlier about even our desirability as an enrollee to want to know about the program we are in. There's an operational guideline. It's on the website. It contains the benefit package. And I bet you the benefit package of the NHI is very comprehensive. We tout ourselves as one of the most comprehensive benefit packages. Almost everything is covered. Almost everything is covered, cancers inclusive. Probably you're hearing that for the first time. I don't know. Cancers inclusive, chronic illnesses, and then...
So why are these HMOs or the healthcare facilities, will come up and tell you, this is not covered under this scheme. This is not... Why do we have that?
That's what I'm saying. When the enrollee is aware, self-awareness, by taking interest in that thing we're participating in, that, these are the benefit packages. And then when you are in a hospital, and like I told you, I said every system, even in the advanced democracies, people want to make gains, So they can say it's not covered. It's now left for you to say, no, that is covered. When they see that, you're right, of course, then, oh, okay, it's a mistake. Oh, I didn't know. And then they provide you with the service. So I advise, yes, on our part, we'll continue hype up the sensitization and awareness, but there is even no sensitization where we would begin to read out the whole things that are covered. But what we have on the guideline, and people can take interest in that, is a drug list that tells you all the medications that you can access under the NHIE, a procedure list to tell you all the operations, surgeries, and all. And I tell you, very comprehensive. They're all there.
You know, a colleague of mine raised the
assessed.
concern. A colleague of mine raised the concern on enrolling beneficiaries into the scheme, and it's taken about 3 months. Okay. Why do we have such delays, or rather, why does the authority allow such delays?
Okay. Well, I don't know exactly if he says it takes 3 months to enroll.
No, like it's 3 months now, and he's not been able to get them into the scheme, his kids.
Okay. So there is actually something we call the waiting period. You may enroll now, but you may not be able to access care until the next 3 months.
What about getting beneficiaries?
6 months. Beneficiaries as in you?
No, not you now, members of your household, enrolling them. That's where he's stuck.
And that's what I'm saying. No, but he can. There is an enrollment center in all of the state offices. You go, you are enrolled. You know, you are taken into the system, but you may not be able to access care until the next 3 months. It's called a waiting period, and it's just one of the strategies to take care of a phenomenon or process that's called adverse selection. So for some of this program, people come to enroll probably only when they are pregnant. And then they pay a small amount or that premium, and then probably they are going to benefit from a surgery that will consume the same contribution that was made by so many people. So that strategy was just put in there to discourage people who would only wait until they need that service. You know, that's the waiting period. But I am very aware that a lot of these processes, we're trying to reform them. And I'm sure before the end of the year, new policies regarding enrollment, how much you even enroll, are going to be published.
Okay, let me bring in the issue of those generic and branded drugs. You know, it's a big issue. So how do you sensitize members of the public, the enrollees themselves, that this? Can you tell us what is generic drug and what is branded drug? Do they have any difference?
Yes. So what the NHIE have in their medicine lists are generics. Now, what generic just means, simply for the layman, is just, the constituents that makes the medicine is what we write there. We don't go writing a brand. For example, I'm Habib. If I make a drug, I can call Habib Clocks. That's my company making that. If we write that in our medication list, it's as if we are marketing for my company. Yeah, sure. So we'll only put that constituent that makes, so that's the generic. Now, and that's what we tell facilities to actually stock, and prescribe. Now, some of them will go out of their ways to prescribe brands, and then when they go to the pharmacy, they are told, no, we do not have this. Some of the times, just the gimmick, in the health insurance thing that we're trying to take care of. But immediately we are notified, oh, it's because it's a brand that you are not getting it. Then we tell you, no, give him the generic. Why are you giving him the brand? Give the generic. And then there is so much noise about, oh, maybe branded are supposed to be superior to generic. But it's all in the mind, of people. If it's a brand, it produces better results or faster results. So it's generic for the NHI. And we have always advocated that healthcare facilities should stick to prescribing generic. Sometimes even pharmaceutical companies go to facilities and please prescribe our medication so that it can doing the marketing for them. But
but what is the NHI, the authority, doing to educate the people? Because that's my worry, to understand that branded drugs and generic drugs are actually of same quality. That because in the minds of the people, it's generic drugs are because the CNHI, because you're paying just 10%, they don't even understand that, of course, they have accumulated money that's actually their money. They feel it's of low quality. So what are you as agency doing to ensure that these people really benefit or reap the fruit of their labor, so to say?
Honestly, we can only step up the awareness. But personally, I think I can count, the number of sensitization that have been in phase staff of MDAs, their HMOs do that, and then we are invited and we see all of these things. Like I say, it's all about people really taking the control of issues that concern them. But yes, we'll step it up. There is presently an enrollee charter that we just developed that speaks to the rights and responsibilities of the enrollee, as well as our commitment to them to ensure quality, and it mentions about all of these things. And the fact that you should know that a generic is no less different from a brand, and generic is what the NHI has advocated that healthcare facilities will talk about. But like I said, we can only do more and more of this sensitization. In the past, it used to be a quarterly thing. I'm sure we've revived that now. I'm very much aware that a lot of states are going to be conducting.
In your sensitization, are you collaborating with other agencies so that you reach your desired target?
So I mean, the collaboration would be better even with the MDAs, who are the stakeholders even in this. So like I told you earlier, the quick win measures, whereby we created a platform where the MDs, NHI representatives or desk officers are involved. What we have said is, look, share with them the entire operational guideline, share with them the entire drug list, the procedure list, and so on and so forth, so that these people will equally go back to their own MDAs and then step down this knowledge.
You know why I asked that question? Because of Uche's concern about education, sensitizing the people. If you said it's the bulk of the work of sensitization, will involve carrying the MDAs along, are you actually pushing? Because if these MDAs, that's where the gaps are, people are not in the know. Are these MDAs complying with the aspect of sensitizing the citizens that, okay, that's their own...
Obviously, from the questions, I mean, you work with the NTA, and I'm sure from the questions they are probably...
NTA is not part of... NTA is doing its own bits of it.
No, I mean, no, what I'm saying, in essence, is that, look, if there is still that gap in people not knowing their rights and their responsibilities, then obviously those people who are supposed to be stepping it down to them are not doing it. So what we can do is, again, study and see what other measures we can bring up. Like I said, every state office, I'm aware of that, in the last 1 week, I've been told to organize sensitization awareness programs in their states. They will call the HMO reps, they will call facilities, as well as representative of MDs. But a representative of an MDA will go there. He will take in all this education, and it's now left for him to find a means of also stepping it down to his own people back home. So probably what we'll now be looking at is developing a strategy for those people
and working closely with the media. We are doing our part right now, NTA. You have to work closely with the media.
We do that. I myself have been on radios, on TV, on behalf of my DG. It has always been there. We will continue. We'll step up with activities.
I like the word step up.
No, it's actually step up. But you see, it's the Nigerian factor. You can't divest that out of here. I mean, you are asking questions yourself. I mean, these are questions probably that you didn't know yourself. You should have known, because you've been in the ATA for long. You've been enrollees of, and they are all there in the open. They are on the website. We've had sensitizations in the past and so on. You know, so like I said, compare it with PFA. Everybody knows how much is contributing, how much, but we don't want to know.
Okay, Dr.
about
Abdul Hamid, we're rounding up, and you know, I got a report from the authority that Basic Healthcare Provision Fund supports about 2.67 million beneficiaries nationwide, including 800,000 newly enrolled this year. Now the question is, going forward, are there strategies in place to ensure the expansion of enrollment for beneficiaries? So, very briefly.
If you're talking about the BHCPF, like I mentioned from the beginning, this is a program done for like the vulnerables in conjunction with states. So the federal government, 1% of Consolidated Revenue Fund is set aside annually, and through 3 gateways for NHIA, Primary Healthcare Development Agency, and the emergency, team. And then state office put their counterpart. So it's for those who cannot afford. People don't pay for it. Federal government and the state. And it will only be based on what you have. The funds is what will determine the number of people. So if you have maybe next year now, a bigger budget or a bigger CRF, Consolidated Revenue Fund, that has more money in it, and then more contribution from the state, then probably more the numbers will increase. But for the BHCF, it will always be dependent on what amount of money we're able to get for that year.
All right, I think that's where we'll wrap the conversation up, because there's more. There's a lot, to explore. But we'll just, for us here in NTA, we'll lend our voices, for the sensitization. We're doing our part. Thank you very much, Dr. Habib Abdullahi Abdul Hamid. He's the Acting Director of Enforcement from the National Health Insurance Authority. Thank you. And keep up with the good work you're doing.
Thank you for having me.
All right. Uche Ugochukwu, our health correspondent here in NTA, thank you. I'm sure now you know where to go. There won't be any complaints.
Of course.
All right. Okay, so we've been looking at ways to improve quality services through, universal health coverage. It is your right, but like they say, information is power, and having access to that information lies with you. So do the needful. And that's Platform. I'm Ruth Aguele.